Dear friends, hello and thank you for being so faithful. We have seen in chapter 3 that the eyelid peeling without any other adjuvant treatment gives the best visual improvements in macular edema with a gain 2 to 3 times greater than that given by the anti-VEGF. And this regardless of the origin of the edema and whether or not it is accompanied by an epiretinal membrane. It is easy to understand why some laboratories didn't want to carry out comparative studies, surgery versus anti-VEGF. Now let's see what parameters can lead a doctor to propose this surgery. Before starting, I would like to point out that while the 3 previous chapters are, based on anatomo-clinical findings, this chapter on indications is a reflection of my way of seeing things and only involves me. The intensity of the reflections emitted by the epiretinal membrane, when there is one, is certainly not an argument for an operative indication. This reflection is due, as we have seen, to the presence of posterior haloid fibers attached on the eyelid and disorganized by a glial proliferation in reaction to ischemia. Very reflective membranes surrounding a pseudomacular hole with a visual acuity of 20/25, invariable for 2 years, can very frequently be seen. For me, this means that an ischemia occurred, that there was an adhesion to the posterior haloid fibers, that the retina was able to react to ischemia by creating an intense astrocytic gliosis, and that this reaction was strong enough to avoid a progressive visual loss. There is, in my opinion, no reason to propose a treatment to such a patient in the absence of metamorphopsia or any OCT evolution. The presence of metamorphopsia disturbing the patient may, however, justify the proposal of surgery, especially if it is accompanied by retinal folds or foveal ectopia. How many patients with 20/25 on one eye are forced to close this eye to dry and will be grateful to you for operating on them, even in the absence of any improvement in their pure visual acuity. This is why, if metamorphopsia accompany a progressive visual loss or an increase of the edema at the OCT, you will be less reluctant to propose a surgery because you will be sure that at least the patient will be happy. The verified and progressive decrease in visual acuity is, of course, one of the key elements of the surgical indication as for cataract. But the reasons for edema surgery are different from those for cataract surgery. They are closer to those for glaucoma surgery because even if postoperative visual improvement is important, it does not catch up for everything lost. And I was often struck by the fact that some operators did not hesitate to operate a cataract at 20/23, while there is no hurry. The recovery will be the same if they wait a little longer. But advocated a caution abstention for progressive edema, which led to a progressive decrease to 2030, while the rate of postoperative complications, including retinal detachment, is perfectly identical to that of cataract surgery. It is true that the more the operator waits for a visual loss, the greater the improvement brought by the surgery will be, and perhaps the grateful patient. But if we consider not the gain induced by the operation, but the final visual result, we can see that the earlier the operate, the higher the final vision is. This means that the better recovery of low acuities does not compensate for the initial vision loss. So, of course, we are not going to operate at 2022. For me, a good way of considering things is to expose the patient to the risk that he will no longer be able to read. Well, it will be 5% if operated at 2040, 10% if operated at 2050, and 30% if operated at 2100. So to get into everyday practice, what are the limits of my indications? First of all, I would not use the condition of the other eye, even if it is perfectly healthy with 20/20 vision, because we only have two eyes. Do not have a lower limit, because going from 2400 to 2200 is as important as going from 2100 to 2050, if, unfortunately, this eye becomes the only functional eye. So, of course, everything must be considered. An elderly patient, disoriented and in poor health, with 2400 due to a microcystic edema, is not necessarily a patient to convince, especially if the other eye is better. As for the upper limit, I have already said, a patient with 20/25, if he is bothered by metamorphopsia, can be operated. In the absence of metamorphopsia, two things must be considered. First of all, the evolution of the visual decline. A patient who has 20/40 for 3 years is not necessarily a candidate for surgery. But a patient who in the last 4 months goes from 20/25 to 20/30 is much more so. And in case of doubt, it is the OCT that decides. An increase in the macular volume being certainly an encouraging element for the intervention. And OCT, since we are talking about it, has of course revolutionized indications in edema by showing pure edema without membrane reflection that only angiography previously allowed it to detect, tractions on the posterior haloid invisible with the biomicroscope, and unsuspected images like foveoschisis, and also all the pathology of the eye myopia. In addition, the OCT will give you a documentation that can help you in case of legal problem, and especially can facilitate the communication that you will have with your patient when the time comes to expose the benefit-risk ratio so that he can make an informed decision. The benefit is simple to expose. Over 95% chance to stop the evolution loss, the visual loss, and give back an improvement, and almost 100% chance to eliminate metamorphopsia. As for the risks are concerned, you will need to report endophthalmitis, less than 1 per 1,000. Your risks of post-operative detachment, depending on your technique, complete or partial vitrectomy, complete or limited removal of the posterior haloid, duration of the intervention, number of sclerotomies, etc., etc., and the vitrectomy machine you will use, because according to the EVRS floater study, a machine equipped with venturi pump statistically drives 5 times more retinal detachment than a flow control machine. For me, the risk of detachment was 2%, the risk of losing sight in case of detachment being less than 5%, the global risk of losing sight after edema surgery was turning around 1 among 1,000. Finally, the risk of accelerated onset of cataract, which also varies from the technique, and especially if the vitrectomy is total or limited to the posterior pole, and from the vitrectomy machine used. I recommend you to prescribe to the patient a large dose of patience. You will explain that the visual improvement will start to take effect after 6 months. If it goes faster, the patient will be lucky and will continue for several years, since after 3 years, as we have seen, the vision is better than after 2 years. You will also be careful to inform your referring ophthalmologist. First of all, the time required to achieve optimal visual recovery. Secondly, not to suffer the tyranny of OCT in postoperative care, because, as we have seen, there is a usual increase in retinal thickness after 2 years, probably related to the progressive filling of the Müller cell by GFAP. The classic and typical story is that of a patient referred for a central vein occlusion with 2200 vision that you operated on and who recovers 20/30 after 18 months, which is not bad. The referring doctor will readdress the patient back to you for a recurrence with an increase in thickness at the OCT and a vision at 20/60. Frightened by a pathology that for him is extremely serious, he didn't see that the patient has developed a cataract, and after a simple phaco, the patient recovers 20/25. Thirdly, not to inject other adjuvant products, and in particular anti-inflammatory drugs, since, as we have seen, inflammation plays a positive role in the development of Müller cell gliosis. I will finally remind you 2 last tips based on the etiology of the edema. Firstly, for edema after vein occlusion, do not forget to remind the patient about the importance of fighting against the contributing factors. ocular hypertonia, intolerance to hypoxia, etc. At least to preserve the other eye. Last but not least, for diabetic edema, do not forget to insist on obtaining a normalization of the constant before the operation. Be voluntarily quite hard in your requirements with diabetic patients because it is your role as a doctor to be. Do not hesitate to write to the diabetologist and refuse to operate the patient if the inflammatory status is not good and if the blood pressure and the glycated hemoglobin are not normalized. Let's not forget that the major disadvantage of surgery is that ILM peeling is a one-shot treatment. The ILM does not grow back, and the only way to induce trauma-generating Müllerian gliosis in case of recurrence is to create a retinal detachment with all the risks it entails. Also, tell your patient that edema surgery does not exempt from laser treatment on peripheral non-perfusion areas, especially since it is described that a much anterior PRP can treat a macular edema. And of course, encourage the patient to continue normalizing the constants. The long-term results of diabetic edema are worse than those after vein occlusion due to the progression worsening of diabetic microangiopathy. A last word to the young retinal surgeons who start. You have seen the results, and the results are published in peer reviews. So remain scientific and critical in your indications, and do not succumb to the siren song that offer you travel and registration in congresses. A Formula One driver will not choose to race with a less efficient car on the pretext that is offered the trip to the circuit. Your wealth, you will get it from your result above all. So, here is what I wanted to tell you about my surgical indication in edema and idiopathic membranes before addressing the surgical tips and tricks that we will see from the next chapters.